Welcome back to series of lectures in endocrinology. This is where we're going to get to discuss the general endocrine system. So there are a lot of hormones that we've started discussing. Today we'll be discussing lecture 5 of the endocrine system. So here, this is where we'll be discussing the thyroid gland. So the thyroid gland is responsible for the production of two major hormones, the T3, T4, Trihydrothyronine, and the tetraiodothyronine, which is also referred to as thyroxine. And of course, we have the paracellular cells or parafollicular cells. The parafollicular cells are responsible for producing calcitonin, that is also involved in the metabolism of calcium. So for now, let's discuss the thyroid hormones, which are also referred to as metabolic hormones, because they will increase the metabolism of the body by increasing the hormones that are involved in metabolism, by increasing the presence of ATP, the adenosine triphosphate, which is the form of energy where a lot of metabolism are using, and also by increasing sodium, potassium, ATP as pump to transport a lot of electrolytes, substances in and out of the cell. So the cells will be very active under the influence of the thyroid hormones. So we'll look at the metabolic functions of the thyroid hormones later on, but we need to start by looking at the production, the function, and later on we'll discuss the disorders. That will be just like the layout of lecture 5 in endocrine. So the thyroid hormones, which are also referred to as metabolic hormones, the thyroid gland is located immediately below the larynx on each side of and anterior to the trachea. So the thyroid hormones is under the larynx, so it's inferior to the larynx, but is on the anterior aspect of the trachea. So there are three lobes that are connected, but they are just in front of the trachea or the windpipe. That's the location, the anatomical location of the thyroid gland. It produces two major hormones, thyroxine and triiodothyronine. The triiodothyronine is a hormone produced by the thyroid gland, and also thyroxine, which is also referred to as T4 or tetraiodothyronine. So they are commonly called T4, T3 respectively. So both of these hormones profoundly increase the metabolic rate of the body. So they are going to increase the metabolic rate of the body by increasing the number of enzymes that are involved in metabolism. So it will have an effect on DNA transcription. So we'll look at the effect of thyroid hormones on the cells, the target cells. This is the anatomical location of the thyroid gland. So you can see it's just inferior to the larynx. Then it forms like a tie to the trachea. So behind you have the trachea. The thyroid gland is on the anterior aspect of the trachea. Then you have three lobes. So you can see the right lateral lobe and the left lateral lobe. And then at the center there, we have the pyramidal lobe of the thyroid gland. So they are connected by the isthmus. So you can see the connection of the three lobes here. There is a very good blood supply to the thyroid gland, because once the hormones are being produced, for them to produce the hormones, you need iodine. Iodine is coming from the diety, or iodide, that is coming from the diety. Then once the thyroid hormones are being produced, they need to be transported by the cardiovascular system. So you can see that the blood supply to the thyroid gland is very good. So we have the branches of the common carotid artery. So we have the branches from the common carotid artery that is supplying the thyroid gland, the superior and the inferior thyroid arteries that are supplying the thyroid gland. Then we also have the superior and inferior thyroid vein that are connecting to the jugular vein. So you can see the jugular vein there. We have these veins that are draining the thyroid gland. Then they will be transporting the hormones to the target cells. But the blood is brought in by the arteries, which are mainly the branches of the common carotid artery. Okay. When we take a cross section of the thyroid gland, you're going to see the choroid or the follicles. So the choroid are called the follicles, At the center there are a lot of proteins that are being secreted into the choroid. So this is just a fluid network of proteins that are being secreted by the follicular cells. The follicular cells are the ones that are producing the hormones, and then they will be stored within the colloids, or some other reactions are taking place within the colloids. So we have intracellular reactions in the production of thyroid hormones and extracellular reactions that are taking place in the choroid for the production of thyroid hormones. Then adjacent to the follicular cells, we do have the parafollicular cells. The parafollicular cells are producing calcitonin. Calcitonin is an antagonistic hormone to that of PTH, parathyroid hormone. So they are involved in the regulation of calcium. So the concentration of calcium is affected by the two hormones, the parathyroid hormones and also calcitonin. The calcitonin is not produced by the follicular cells, it's not produced by the parathyroid gland, they are produced by the thyroid gland. So you need to know that in the thyroid gland, you have the parafollicular cells that are responsible for the production of calcitonin. So calcitonin mainly is being secreted when you have an increase in calcium concentration. In case of hypercalcemia, there will be secretions of calcitonin that will try to bring down the concentration of calcium, of which we are going to discuss later on. The thyroid metabolic hormones, so there are two, like I said. The thyroid secretion is controlled primarily by the thyroid stimulating hormone. So we are talking of the hypothalamus pituitary gland axis. So we say that the hypothalamus, we have those nuclei, the ventral nuclei of the hypothalamus that are producing thyroid stimulating hormone. The thyroid stimulating hormone will be transported by the portal system to the anterior pituitary gland. It will go there and stimulate the cells that are producing thyroid stimulating hormone. So remember, we had the thyrotropes. The thyrotropes were producing thyroid stimulating hormone. So for them to release the thyroid stimulating hormone, they need the presence of thyrotropin releasing hormone. So the thyrotropin releasing hormone is produced by the hypothalamus. Then the thyrotropes now will be stimulated to release a lot of thyroid stimulating hormone. So that's the control of hormone release from the anterior pituitary gland. The thyroid gland also secretes calcitonin, which I mentioned, an important hormone for calcium metabolism. So we are going to discuss this when we start looking at calcium metabolism under the parathyroid hormone. About 93% of metabolically active hormones secreted by the thyroid gland is thyroxine, and 7% is triiodothyronine. So the thyroid gland is producing about 90 to 93% thyroxine. Then the 7%, 10 to 7% is triiodothyronine. So 7 to 10% triiodothyronine. It simply means that the thyroid gland is producing more of thyroxine as compared to triiodothyronine. However, almost all the thyroxine is eventually converted to triiodothyronine in the tissues, so that both are functionally important. In terms of potency, the triiodothyronine is more potent as compared to thyroxine. In terms of stimulating chemical reactions, the triiodothyronine is more potent as compared to thyroxine. So when thyroxine has been delivered to the tissues, it will be absorbed by the tissues, it will enter the tissues, then within the tissues it will be converted back to triiodothyronine. Remember, the difference is just the number of iodide that is attaching to these hormones. So in tetraiodothyronine you have 4 iodide, in triiodothyronine you have only 3 iodide. So if you have a iodinase reaction whereby you have iodinase enzyme that will remove iodine, then the thyroxine can be converted to triiodothyronine, or the tetraiodothyronine can be converted to triiodothyronine within the tissues. Then that will render this hormone are very effective at stimulating chemical reactions, and also the cell will respond because of that. The functions of these two hormones are quantitatively the same, but they differ in rapidity and intensity of action. So the rapidity and intensity of action, it's more rapid and it's more intensive for triiodothyronine as compared to tetraiodothyronine. That's why we are saying that at tissue level, the thyroxine or the tetraiodothyronine has to be converted to triiodothyronine so that it becomes rapid and intensive in terms of action of this hormone. The triiodothyronine is about 4 times as potent as thyroxine, but it is present in the blood in much smaller quantities and persists for a much shorter time than does thyroxine. So thyroxine has got a longer half-life as compared to triiodothyronine. So you realize to say that the thyroid gland is producing a lot of thyroxine that will spend more time in circulation. Then later on, when it's delivered to the tissues, it will be converted to triiodothyronine, so that in terms of function, they should be similar. Iodine is required for the formation of thyroxine, so the production of thyroid hormones. The biosynthesis of the thyroid hormone, how are they produced by the follicular cells within the thyroid gland? So this is the information that you need to bless yourself with so that you are able to understand and also apply the knowledge. For the production of thyroid hormones, you need iodine. So iodine is required. This iodine is coming in from the diet in form of iodide. So iodide can be absorbed from the GIT, transported by the bloodstream to the thyroid gland. In the thyroid gland, there are proteins, sympathetic proteins, that are involved in iodine trapping. So the iodine will be trapped by this sympathetic protein. It's involved in secondary active transport. So it's using the concentration gradient for sodium. As the sodium is entering the cell, it will help pump the iodide into the cell. So this is called iodide trapping or iodine trapping. So most of these follicular cells now, they are internalizing iodide and also sodium on the basolateral side of the membrane. Then on the apical side, there is exocytosis of the proteins, the thyroglobulin. I'll explain. So after the trapping of iodide, you are introducing a lot of sodium. This sodium can be exchanged for potassium because we do have sodium potassium ATPase pump that are pumping 3 sodium into the interstitium, is pumping 2 potassium into the follicular cells. Then this potassium, when it's accumulating here, it can easily move across the potassium leaky channels because most of these cells, they do have potassium leaky channels. So the concentration will balance itself depending on the concentration gradient. So potassium will start leaking out of the cell. So this is the internalization of iodide. This iodide will undergo a reaction to form iodine, and the iodine will be pumped into the colloids. So the iodine, we have the iodine protein here. The iodine protein or the pendrin protein is the one that is going to pump the iodine now into the colloid, reacting with the thyroglobulin. The thyroglobulin is a complex of protein that is produced by the rough endoplasmic reticulum. You know, to say for the rough endoplasmic reticulum to produce a protein, it requires message that is brought in by the messenger RNA. After transcription of DNA in the nucleus, there is the messenger RNA that will move to the rough endoplasmic reticulum for translation of the protein. Then it will produce this protein. It will be packaged within vesicles, transported to the Golgi apparatus for modification. Then the Golgi apparatus will package again this protein, which is called the thyroglobulin. The thyroglobulin will be packaged into vesicles, transported by molecular motors to the apical side of the follicular cells, where there will be exocytosis of the thyroglobulin protein into the colloid. So you're releasing this complex of protein into the colloid. But remember, you need tyrosine, because for the production of thyroid hormones, you need tyrosine. So the thyroglobulin protein contains a lot of tyrosine as well. So you have a complex of proteins here. Then with the presence of iodine that was pushed into the choroid, there will be now iodination reaction that will take place. So to the tyrosine, if you just add one iodine, then to become MIT, the monoiodotyrosine. Monoiodotyrosine. If you add 2 iodide, then to be converted into the diiodotyrosine. Then the monoiodotyrosine can react with the diiodotyrosine to form the tetraiodothyronine. So there is a coupling reaction that is taking place there after iodination. If the monoiodotyrosine is reacting with the diiodotyrosine, they will form the tetraiodotyrosine, the tetraiodothyronine now. Then if 2 diiodotyrosine are reacting with one another, they will form the tetraiodothyronine. Tetraiodothyronine. So this is the production. So these are hormone precursors that are still bound to the thyroglobulin protein. So at this point, they can't be released, so they need to be internalized by the same follicular cells. So these are the reactions that are taking place within the choroid. Then they'll go and bind to receptors. So you can see that this thyroglobulin protein that is containing the monoiodotyrosine, diiodotyrosine, tetraiodothyronine, and triiodothyronine. It's a complex of these hormones that are bound to the protein. So they'll come and attach. There will be endocytosis. So there is endocytosis. Here you had exocytosis of the thyroglobulin protein, but here now you have the endocytosis after iodination reaction. So you have this complex of enzymes that are contained within the vesicles. So this vesicle now will fuse with the rhizosome to form the endorhizosome. The endorhizosome, of course, in the rhizosome you have a lot of enzymes that will now break out some of these hormones. So they will come and split the tetraiodo and the triiodo from this complex. So you can see the release of triiodothyronine and the tetraiodothyronine. That will be exocytosed again into the circulation. So it will be transported by the blood vessels to the target cells. And then the complex still contains the monoiodotyrosine and the diiodotyrosine. So the monoiodotyrosine and the diiodotyrosine, it will undergo iodination reaction. So here you have iodinase enzyme that will remove the iodine from the tyrosine. The tyrosine amino acid will be recycled for the production of more thyroglobulin molecules. Then the iodine will be also recycled for the production of more thyroid hormones. So this procedure will repeat itself. But remember, for this follicular cell to produce a lot of thyroid hormones, it needs a stimulus. The stimulus is the follicle stimulating hormone. Not the follicle stimulating hormone, but the thyroid stimulating hormone. Remember, we had a thyroid stimulating hormone that is being produced by the anterior pituitary gland under the influence of thyrotropin releasing hormone that is coming from the hypothalamus. So the hypothalamus will produce the thyrotropin releasing hormone. Then it will go to the anterior pituitary gland to stimulate the thyrotropes to release and produce more of thyroid stimulating hormone that will go in circulation to go to the follicular cells and stimulate the follicular cells to produce and release a lot of thyroid hormones. So the 2 thyroid hormones will be released now, the T3, T4, under that stimulus. It's the same information here, but just expanded for you to appreciate more. So you can see the production of the thyroglobulin. So you have the amino acids tyrosine that will be incorporated within the thyroglobulin molecule. Then it will be modified by the Golgi apparatus, transported by vesicles with the influence of molecular motors. Then we have exocytosis of thyroglobulin protein. Then here you have sodium iodine syn-porter protein that is internalizing sodium and iodide. And the iodide will undergo a reaction to be converted into iodine or iodine, and the iodine now will move via the pendrin protein into the choroid. And then in the choroid, there is iodination reaction taking place there. The iodination reaction is just the addition of iodine to thyroglobulin protein to produce the monoiodotyrosine, the diiodotyrosine, then these they can react to give you tetraiodothyronine and also triiodothyronine. This molecule will be internalized by the follicular cells, so they will come and attach to receptors. So you can see you have the megalin receptor here, where the thyroglobulin molecule is going to attach with these precursor of hormones. Then it will be endocytosed in form of vesicles. And these colloid in endosomes will now fuse with the rhizosome, where you have proteases or enzymes that will break out certain hormones now. Then the hormones will be released to the circulation. Then the MIT, the meat, and the DIT, the diet, these will be recycled. So you have deiodination reaction taking place here. Deiodination reaction, you have enzymes that will remove the iodine that will be recycled. Then the tyrosine enzyme amino acids can be recycled. So most of these amino acids can be recycled for the production of the thyroglobulin protein. Okay, so it will repeat itself. The thyroxine and triiodothyronine are bound to plasma proteins after secretion into the blood. You know to say that the thyroid hormones, tetraiodothyronine, triiodothyronine, are fat soluble. So once they are released to the circulation, they need to bind to plasma protein for them to be transported. Otherwise, they can't dissolve in plasma. So about 90 to 99% of these hormones are actually binding to plasma proteins for their transportation. Maybe just 1% of these hormones will be transported as free hormones, but most of them, they will bind to plasma proteins for their stability as they are being transported. So they combine mainly with thyroxine binding globulin. So we have thyroxine binding globulin, which is an example of a plasma protein, globulin protein, produced by the liver hepatocytes, and then it will be binding with thyroxine, and much less so with thyroxine binding pre-albumin and albumin. So albumin can also bind, so not much of it is binding with albumin, but very few of these hormones are binding with pre-albumin and also albumin to be transported, because albumin is also part of plasma proteins. So because of a high affinity of plasma binding proteins for thyroid hormones, these substances, in particular thyroxine, are released to the tissue cells slowly. So the release of these hormones to the cells is slowly. That will improve on the half-life or the shelf life for these hormones. It's going to be increased because they are binding to plasma proteins, but they are slowly released to the tissues for their usage. So you find that that is going to prolong the half-life or the lifespan of the thyroid hormones. So they're going to be used by the tissues slowly because they are being released slowly to the tissues. So on entering the tissue cells, both thyroxine and triiodothyronine again bind with the intracellular proteins, the thyroxine binding more strongly than the triiodothyronine. So even here, after T3, T4 has been transported to the tissues, then they'll cross the phospholipid bilayer of the cells to enter the cells. Within the cells, they also bind to the intracellular protein, because in the cells we have cytoplasm. Cytoplasm is liquid or water. So these hormones, they still don't dissolve well in cytoplasm. So you still need a lot of intracellular proteins to bind with the thyroid hormones to be transported to the nucleus, because the receptors or thyroid hormones is located within the nucleus. So again, they are stored within the cells. So that is also going to improve the half-life of these cells, or the shelf life of the cells. I mean, not the cells, but the hormones, the thyroid hormones. Therefore, they are again stored, but this time in the target cells themselves, and they are used slowly over a period of days or weeks. So after the production of thyroid hormones, they can be used over a period of days or weeks. Why? Because during transportation they are stored, and when they enter the target cells, they are also stored there. So they are used slowly by the cells. So the effect of thyroid hormones can take a bit of time. So thyroid hormones have a slow onset and long duration of action. So the duration of thyroid hormones will be elongated because they're being stored at the level of transportation, and within the target cells they are stored again. So they will slowly have an effect on these cells. that are using the thyroid hormones. What are the physiological functions of thyroid hormones, or physiologic function of thyroid hormones? What do they do to the cells? The thyroid hormones will increase the cellular metabolic activity. The cellular metabolic activity of the cells is going to increase. That's why they are referred to as metabolic hormones, because they are going to increase the production of ATP, they're going to increase the production of enzymes that are involved in metabolism, they're going to increase sodium potassium ATPase pump, so the metabolism of the cells are going to increase. So the thyroid hormones are going to increase the cellular metabolic activity. Thyroid hormones increase the number and the activity of mitochondria. So the number and the activity of the mitochondria, they are also going to increase. With the increase in thyroid hormones, you expect an increase in the number of mitochondria. In the mitochondria, they are involved in energy transduction to convert one form of chemical energy to another form of chemical energy. So you saw that a lot of energy is being transducted from one form to another form. The form that is being produced there is the ATP that is also required for metabolic processes. Thyroid hormones increase active transport of ions through the cell membrane. So it's going to increase the active transport of ions. Why? It's because an increase in the thyroid hormones is going to increase the production and translocation of sodium potassium ATPase pump that is involved in active transport. Thyroid hormones is going to promote growth and development of the brain during fetal life and for the first few years of postnatal life. You need the thyroid hormones for the development of the brain during fetal life and the first few days postnatal life. The baby requires thyroid hormones for normal development of the brain tissue. So I suspect maybe my mother had a lot of thyroid hormones when she was giving birth to us. I'm saying us because we are the two of us. We are twins, myself and my twin brother. So I suspect maybe she had a lot of thyroid hormones. That's why our brain developed so good, and the memory is relatively good. I can say that. I can boast of that. Anyway, we continue. What are the metabolic effects of the thyroid hormone? The thyroid hormone stimulates almost all aspects of carbohydrate metabolism. So whatever aspect of carbohydrate metabolism you can think of that you discussed in biochemistry, they are being activated by the thyroid hormones as well. These will include rapid uptake of glucose by the cells. So for the cells to internalize glucose, they can be facilitated by thyroid hormones, because in turn thyroid hormones will increase the secretion of insulin. So if you have insulin, even the internalization of glucose by the muscle cell, adipose cells, and all other cells of the body that can respond to insulin, they will increase internalization of glucose. So it is important for you to have thyroid hormones to increase the rapid uptake of glucose by the cells, enhance glycolysis, so enhance glycolysis, then also enhance gluconeogenesis. Gluconeogenesis, you know, to say this is the production or the synthesis of glucose from non-carbohydrate sources. So you're using lipids, you're using protein to produce carbohydrates. So you have the thyroid hormones that can enhance gluconeogenesis, increased rate of absorption from the gastrointestinal tract. The gastrointestinal tract, they are using a lot of secondary active transport and primary active transport. So the internalization of electrolytes, nutrients from the GIT, it can be facilitated by thyroid hormones. The level of ATP is going to increase, the amount of sodium potassium ATPase pump is going to increase, and also the amount of other channels that are responsible for absorption of nutrients from the GIT, they are going to increase. So they are going to enhance the absorption from the gastrointestinal tract, and of course reabsorption in the kidneys. So you need the thyroid hormones that can also facilitate reabsorption in the kidneys, because you still need ATP there, you still need sodium potassium ATPase pump and other pumps. Even increased insulin secretion with its resultant secondary effects on carbohydrate metabolism. You know, to say cells to internalize glucose, they need insulin. The insulin goes to bind to insulin receptors activating the insulin receptor substrate, which is a tyrosine kinase, and these kinases will activate enzymes that are involved in translocation of GLUT4 channels. The GLUT4 channels will be embedded within the plasma membrane or the muscle cells and the other cells for them now to internalize glucose. So they'll be able to absorb glucose or to internalize glucose under the influence of insulin. So if the thyroid hormones are increasing the secretion of insulin, they will also increase the absorption or the uptake of glucose by the cells. Those are the secondary effects of insulin. It is the function of thyroid hormones to mobilize lipid from fat tissue. So they are going to increase mobilization of lipid from fat tissue. So you'll be using fat as a source of energy as well. Increased thyroid hormone. The increased thyroid hormone decreases the concentration of cholesterol, phospholipids, triglycerides in plasma, but increases the free fatty acids. So it means that here the presence of thyroid hormones is going to mobilize fats from fat tissue. Cholesterol, phospholipids, triglycerides will be used as a source of energy, and to also increase the free fatty acids that could be used as a source of energy. Increased requirement for vitamins. Vitamins requirements is increased because of thyroid hormones. Metabolisms are increasing. Increased basal metabolic rate because the enzymes that are involved here are also increased. Decreased body weight. If you are using fat sources as energy, it means the body weight will be decreasing as well. You're mobilizing fat, you're mobilizing proteins as the source of energy for gluconeogenesis, generation of glucose from non-carbohydrate sources. All that will lead to decrease in body weight to some extent. And increased blood flow and cardiac output, increased heart rate, and increased heart strength. The thyroid hormones are going to increase the cardiac output because metabolism are increasing. The heart rate is going to increase, and also the strength of contraction is going to increase. The blood flow is also going to increase. So basically the metabolism of the body are increasing. The mode of action for thyroid hormones. We said the receptors are located within the nucleus. Once the thyroid hormones are transported by binding to globulin proteins to the target cells, they will be released to the target cells slowly. Then you can see that T3, T4 is entering the cell because they are fat soluble. They can cross a phospholipid bilayer to enter the cell. But within the cells, the target cells, the T4 has to be converted to T3 because in terms of potency, the T3 is more potent as compared to T4. So it's very fast, and the rapidity or the intensity of its action is very good. So it has to be converted to T3. You have enzyme, iodinase enzyme, that will remove the iodine. So you have deiodination reaction taking place. Just remove one iodine there, then the T4 will be converted to T3. The T3 will be transported by intracellular proteins because it will bind to intracellular proteins, and then to be released to the nucleus. In the nucleus, it will go and bind to thyroid hormone receptor. The thyroid hormone receptor complex can also bind with retinoid receptor. This is going to enhance transcription of DNA into messenger RNA. You have gene transcription here into messenger RNA that will be moving to the rough endopacific reticulum for the synthesis or production of new proteins. And these proteins are required by other systems. So many systems will require these proteins, which could be enzyme. They are also required for body growth. So thyroid hormones have got an effect on body growth. The development of the central nervous system, the brain itself, we said it requires thyroid hormones. So the development of the central nervous system or the brain, it has got an effect on cardiovascular system to increase the cardiac output. The tissue blood flow is going to increase. There will be an increase in the heart rate and the force of contraction. The heart strength of contraction is going to increase. Then it can also increase respiration. So all form of metabolism is going to increase. So you can see on metabolism here, there are a lot of things that are increasing. The number of mitochondria is going to increase the production of ATP. The number of sodium potassium ATPase pump is increasing. These are the enzymes that will also break down ATP to transport ions against the concentration gradient. You have oxygen consumption that will increase. If you have more mitochondria, it means you're using more oxygen, because we said in the mitochondria, the oxygen will function as the final electron acceptor in the electron transport chain at complex number 4. So that's where the oxygen will accept the electrons and then bind with hydrogen ions for the formation of water. So if you're producing a lot of mitochondria, it means you are also using a lot of oxygen, which makes sense. So oxygen consumption is going to increase. There will be an increase in glucose absorption by the cells, because it will increase the secretion of insulin. Internalization of glucose by the cell will be facilitated by insulin, and also the secondary effect of insulin will be observed within the cells. There will be an increase in gluconeogenesis. You are producing glucose from non-carbohydrate sources, so you're using fats, you're using proteins to produce glucose. So it means that the body will start losing weight, because you're breaking down proteins, you're breaking down fats to produce glucose. There will be an increase in gluconeolysis, in glycogenolysis. There will be an increase in glycogenolysis. So it means you're breaking down glycogen as well. Then there will be an increase in lipolysis. Lipolysis, you're breaking down fats for the source of energy, and also to use part of that fat in gluconeogenesis. Protein synthesis, which could be enzymes that are involved in metabolism. So you have an increase in basal metabolic rate. This is the effect of thyroid hormones. So we are done with the physiological function of thyroid hormones. We know how it's going to stimulate the cells to produce a lot of enzymes or proteins that are required for body growth, that are also required for increase in cardiac output, the force of contraction, and also the rate of contraction or the heart. So we have those aspects, and then the metabolism are also increasing. So you understand all that. But if you have overproduction or underproduction of thyroid hormones, what could be the effect on the body? So let's look at the disorders affecting the thyroid gland or the thyroid hormones. The first one is hyperthyroidism. Hyperthyroidism. From the name itself, hyper, it means it's on the higher side. Thyroidism is the activity of the thyroid gland. So in hyperthyroidism, the thyroid gland is stimulated more to produce a lot of thyroid hormones. This is a condition that occurs due to excessive thyroid hormone secretion. The thyroid gland is stimulated more to produce a lot of thyroid hormones in hyperthyroidism. In most patients with hyperthyroidism, the thyroid gland is increased to 2 to 3 times the normal size. The normal size of the thyroid gland is going to increase maybe 2 to 3 times. Why? It's because there is overstimulation of the follicular cells that will increase in size. It will bring about hypertrophy of the follicular cells, the goiter itself. Also, each cell increases its rate of secretion several-fold. So the amount of hormones that are being secreted from each follicular cell is also going to increase in hyperthyroidism. The plasma thyroid stimulating hormone concentration are less than normal, rather than enhanced in almost all patients, and often are essentially zero. It means that the concentration of thyroid stimulating hormone is going to be less in plasma. Why? It's because of the negative feedback mechanism. Pay attention. If you are producing a lot of thyroid hormones, T3, T4, they will send a negative feedback mechanism to the hypothalamus to reduce the production of thyrotropin-releasing hormone. They will also send a negative feedback mechanism to the anterior pituitary gland to reduce the production of thyroid-stimulating hormone. So the plasma concentration of the thyroid-stimulating hormone is going to decrease in hyperthyroidism because of the negative feedback effect of the two hormones. There are a variety of ways in which hyperthyroidism can develop. So what can cause hyperthyroidism? Among these are hormone secreting tumors or the thyroid gland, hormone secreting tumors or the thyroid itself. This condition is very rare. So it's very rare to have a tumor within the thyroid gland that is producing a lot of thyroid hormones. It happens, but it's very rare. The most common are due to the autoimmune disease. Autoimmune disease called Graves' disease. The Graves' disease is an autoimmune disease whereby your own immune cells will start producing antibodies that can recognize the same receptors where the thyroid stimulating hormone is supposed to attach on the follicular cells. So these antibodies can go and attach and stimulate the follicular cells. Then they'll start overproducing thyroid hormones. Graves' disease is more common in women and may have a gradual onset, typically beginning between the ages of 20 to 40. So between the age of 20 to 40 in females, this disease is common as compared to females because of hormonal issues in females. The plasma of the patients with Graves' disease contains antibodies that recognize the tumor-stimulating hormone receptor, the thyroid-stimulating hormone receptor. So they are recognizing the thyroid-stimulating hormone receptor on the thyroid gland and stimulate it. So these antibodies that are produced by the immune cells, the white blood cells, that's why it's called an autoimmune disease. So your own white blood cells are producing antibodies that can go and bind to thyroid stimulating receptors on the follicular cells. Then the follicular cells are overstimulated. The thyroid gland respond to these antibodies. So they're going to respond because they will think that these are thyroid stimulating hormones that are stimulating them. As long as the receptors are activated, then that pathway is going to be activated. Then you know to say that here now, then the metabolic effect of thyroid hormones will be seen because the production of thyroid hormones is going to increase. So this response causes hypertrophy of the thyroid and increased thyroid hormone production because there is no way for the thyroid hormones to turn off antibody production by negative feedback. The production of these antibodies, they are not responding to the negative feedback of the thyroid hormones. Even if you have more thyroid hormones, they are not going to be turned down to produce the antibodies because there are different cells that are producing these antibodies and they don't have an idea of what thyroid hormones are. They don't have receptors for thyroid hormones, so they're not going to respond to the thyroid hormone by reducing the production of antibodies. So they are continuously being produced by autoimmune cells. Then those will go and bind to the thyroid stimulating receptors of the follicular cells, stimulating them to increase the production of thyroid hormones. Then the thyroid hormones will have metabolic effects that you will see in the disease of hyperthyroidism. The hypertrophy produced by the constant stimulation of the gland result in a goiter. So you can see the enlargement of the thyroid gland, which is called the goiter. So the presence of the goiter in and of itself does not distinguish between the hypothyroidism and the hyperthyroidism because both types of disease can result in thyroid hypertrophy. When you see a patient with a goiter, you don't have to rush to say this is a hyperthyroidism. Why? It's because even in hypothyroidism, you can still have hypertrophy of the thyroid gland. That will still give you a goiter. So the presence of the goiter doesn't give you the diagnosis to say it's a hyper or hypothyroidism. You can only come up with a definitive diagnosis when you measure the concentration of these hormones in plasma. If you have a goiter and then you have an increase in the production of thyroid hormones, then you are good to conclude to say this is hyperthyroidism. But if you measure the concentration of these hormones and then you realize to say the concentration is low, then you'll be dealing with hypothyroidism. In both cases, you're going to see the goiter. So the presence of the goiter is not pathognomonic for hyperthyroidism. So that clinical sign, you need to do some more investigations for you to come up with the definitive diagnosis, whether it's a hyper or hypothyroidism. So what are the clinical signs or the symptoms of hyperthyroidism? When you have a patient with hyperthyroidism, of course, you see that maybe there is a goiter, there is hypertrophy of the thyroid gland, but that in itself you can't conclude. You need to look at other clinical signs. Maybe you'll be able to tell, because there are clinical signs for hyperthyroidism. There are also clinical signs for hypothyroidism. So if you marry that to the clinical signs, maybe you can get the diagnosis there. So what are the clinical signs for hyperthyroidism? There will be high state of excitability. High state of excitability because you are overproducing thyroid hormones. The cells are very active, the body metabolism are very active, so there will be a lot of hyperexcitability, high state of hyperexcitability, misfiring of action potentials. You know, somebody is just talking this and that, they are very active. Sometimes it could be that they are overproducing the thyroid hormones. Intolerance to heat. If the surrounding environment is very hot, the environment is very hot, there will be intolerance to heat because you will still be producing a lot of thyroid hormones that will increase the basal metabolic rate. If the basal metabolic rate is increasing, the body temperature will also increase. So there will be intolerance to heat. Maybe if the surrounding is just slightly hot, then you'll be feeling very hot because your body is also producing a lot of heat in itself. That's why when it's very cold, people eat a lot as compared when it's very hot. Why? It's because when it's very cold, you eat a lot and the thyroid hormones will be secreted to increase the metabolism of the body. So the metabolism of the body has to increase when it's very cold. That will produce heat to keep the constant internal environment, homeostasis, thermoregulation mechanisms. Then, of course, there will be increased sweating. So these are some of the symptoms. There will be increased sweating because you are producing a lot of heat within you, and then that will result into sweating. Mild to extreme weight loss. You are using proteins, fat as a source of energy. So there is lipolysis. You are breaking down proteins, and then that will result into mild to extreme weight loss. You start losing weight. Varying degree of diarrhea. So there will be diarrhea because now there is a lot of activities in the GIT. There are a lot of channels that are involved in pumping of electrolytes or ions that will bring about a degree in diarrhea. You're pumping a lot of electrolytes into the lumen of the GIT. Water will follow. That will produce a diarrhea. Muscle weakness. If there is muscle activity, you're using a lot of muscle, the end result, there will be muscle fatigue. Then you have muscle weakness. Nervousness or other psychic disorders. So the brain is active, the reticular formation is always active, activating the cerebral cortex. So you have these psychic disorders. You start seeing things which are not there. You start talking things that are not making sense. Why? It's because of the thyroid hormones that are overproduced. Extreme fatigue, but inability to sleep. So you are very tired because there is muscle weakness. So there is extreme fatigue. You want to rest, but you can't rest because the reticular formation is always active, activating the cerebral cortex. So in as much as you are feeling tired, but you are failing to sleep. Okay, so this happens. Tremor of the hands. So you have tremor of the hands or involuntary contraction of the hands. Exophthalmos. Exophthalmos is the protrusion of the eyeballs due to edematous swelling of the retroorbital tissues and degenerative changes in the extraocular muscles. So the tissue behind the eyeball, it will become edematous. So there is edema behind the eyeball. So those tissues now start pushing the eyeball out. Then you'll be looking at somebody, if it's a female or it's a girl, you'll be there passing some compliments to say she has sex eyes, but without realizing to say it could be a disease. Actually, it's a hyperthyroidism because, excuse me, we have a tissue that is becoming edematous just behind the eyeball that is pushing the eyeball out. In as much as you see them as sex eyes, but your friend maybe needs help due to hyperthyroidism. So you can see this lady, she has the eyes that are protruding outwards. Why? It's because of the tissue behind the eyeball is becoming edematous and it's pushing the eyeball outside. Exophthalmos. So these are clinical signs in hypothyroidism. So once you see these clinical signs, you'll be able to tell maybe this could be hyperthyroidism. But don't be in a hurry to conclude. You still need to run some tests for you to come up with definite diagnosis. The opposite is called hypothyroidism. Hypothyroidism. So what happens in hypothyroidism? Any condition characterized by plasma levels of thyroid hormone that are chronically below normal is known as hypothyroidism. The production and the secretion of thyroid hormones now, it's low, below the normal range. Then you have hypothyroidism. The defect in hypothyroidism may theoretically be primary if it's affecting the thyroid gland itself. It could be secondary if it's affecting the anterior pituitary gland, those thyrotropes that are producing thyroid stimulating hormone, or it could be tertiary when it's affecting the hypothalamus. So you have primary, secondary, and tertiary, depending on which level is affected. In most cases, 95% are primary defects resulting from damage or loss of functional thyroid tissue. Damage or loss of functional thyroid tissue is the most common. Or sometimes you can have inadequate iodine consumption. So if you are eating food that are lacking iodine, nowadays they add iodine to your salt. So whenever you are eating salt, you are also taking iodine. So it's very rare for you to find hypothyroidism. Why? It's because we have sufficient amount of iodine that we can access from the salt that you are eating. But if you are fond of buying salt that is not where iodine is not added, sometimes you can have hypothyroidism. Okay. One form of hypothyroidism that exists around the world is due to iodine deficiency and is referred to as endemic goiter. Endemic, it means it's only affecting certain population or certain group of people. So maybe in your country, you are not importing salt where iodine is added. Or maybe in your house, your father is not buying salt where iodine is added. Then the goiter will be endemic to that location. So it's affecting a particular region. That's why it's called endemic goiter, cause of iodine deficiency. So in such cases, the synthesis of thyroid hormone is compromised, leading to decrease in plasma levels of these hormones. So you are producing less of the thyroid hormones. This in turn releases negative feedback on the hypothalamus and the pituitary gland, and the thyroid releasing hormone or thyrotropin releasing hormone levels become chronically elevated in the portal circulation of the anterior pituitary gland. So you know to say that the thyroid hormones are supposed to send a negative feedback mechanism to inhibit the production of thyrotropin releasing hormone or thyroid releasing hormone and also thyroid stimulating hormone. Without these hormones, the negative feedback is not there. So in plasma, the concentration of thyrotropin releasing hormone or thyroid releasing hormone and also thyroid stimulating hormone is going to be more because there is no negative feedback mechanism. Because of that, you know to say that the high concentration of thyroid stimulating hormone, it will go to the thyroid gland to stimulate the follicular cells. The follicular cells will be stimulated, but they are not sensing the iodine. It's not there. So they'll start expanding. So they'll undergo hypertrophy. That's why I'm saying in hypothyroidism or hyperthyroidism, you can still get a goiter. So a goiter is not pathognomonic for hyperthyroidism, nor for hypothyroidism. You need to do some more tests for you to come up with that. The plasma thyroid stimulating hormone concentration is also elevated due to increased thyroid releasing hormone. You know to say the thyroid releasing hormone or the thyrotropin releasing hormone produced by the hypothalamus is stimulating the thyrotropes to release a lot of thyroid stimulating hormone. So its concentration is also going to be more. The resulting overstimulation of the thyroid can produce goiters that can achieve astounding sizes or if untreated. So if it's not treated, then you find that the goiter will continue increasing in size. But this form of hypothyroidism is reversible with iodine if iodine is added to the diet. So if you just add iodine to the diet, you find that it can go back to the normal size. So you can see the hypertrophy of the thyroid gland, which is called goiter, in advanced stage if treatment is not done in good time. What are the symptoms of hypothyroidism as opposed to hyperthyroidism? So now think of the opposite. Of course, if there is hypothyroidism, there is less metabolic hormones, the thyroid hormones, tetrahydrothyronine and trihydrothyronine. So what would be the clinical signs or symptoms? Fatigue and extreme somnolence with sleeping up to 12 to 14 hours a day. So you start sleeping longer hours. So here there will be fatigue because the metabolism are less. Then you start sleeping for longer hours. So 12 to 14 hours a day. You are in class, you are dozing. You are listening to this lecture, you are dozing. Sometimes it could be that you are lacking a lot of thyroid hormones. Maybe you have hypothyroidism. That's why you are dozing right now. Then extreme muscular sluggishness. So muscle activity is going to be very slow. So there will be extreme muscular sluggishness. There will be slowed heart rate, decreased cardiac output, decreased blood volume, and also blood flow. Sometimes there will be increased body weight because you're not using proteins, you're not using fat for the production of glucose in gluconeogenesis. So there will be deposition of proteins and fat. Then you start gaining. So there will be an increase in body weight, sometimes constipation. The movement of nutrients is affected, active transport, secondary and primary active transport is affected. That can result into constipation. Mental sluggishness because we said you need thyroid hormones for the normal development of the brain. So if you don't have thyroid hormones, there is mental retardation or mental sluggishness, meaning that your brain is not fully developed. Maybe this is the case with some of the students. That's why no matter how you try to explain some mechanism in physiology, they don't get it. Maybe it's not because of their own doing. Sometimes it's something beyond you. Maybe you have less amount of thyroid hormones and then you have mental retardation. Failure of many trophic functions in the body, evidenced by depressed growth of the hair, scaliness of the skin, atherosclerosis. So you can have atherosclerosis because you're not using triglycerides, phospholipids, or cholesterol as a source of energy. So there will be accumulation of cholesterol, triglycerides in the blood vessels that will bring about hardening of the skin, atherosclerosis. And you know to say atherosclerosis can result into cardiovascular diseases that can affect the patient. Cretinism is caused by extreme hypothyroidism during fetal life, infants, or childhood. It is characterized especially by failure of the body growth and mental retardation. So during fetal life, if you're lacking thyroid hormones, if your mother is not producing enough thyroid hormones, you can suffer from cretinism. Or if your brain is not producing a lot of thyroid stimulating hormone, then the thyroid gland won't be stimulated. So you'll be producing less of the thyroid hormones. So if you have extreme hypothyroidism during the fetal life, then you can have cretinism. It is characterized especially by failure of the body growth and mental retardation. Congenital lack of the thyroid gland is called congenital cretinism. So you don't have the thyroid gland. You are born without the thyroid gland. It's called congenital cretinism. Sometimes it's due to failure of the thyroid gland to produce thyroid hormones because of the genetic defect of the gland. So you are producing a defective thyroid gland. It's not producing any kind of thyroid hormones. So you still have cretinism. Or from iodine lack in the diet. So if you're lacking iodine in the diet as a baby or as an infant, you can have endemic cretinism. So what are the symptoms of cretinism? The skeletal growth in the child with cretinism is characteristically more inhibited than in soft tissue growth. So the bones are affected more as compared to the soft tissue. I told you to say you need a thyroid gland for the body to grow as well. In as much as you need the growth hormone, you also need the thyroid hormones that will engineer the metabolism. So if you are lacking a lot of thyroid hormones as an infant, the development of the bone will be affected. The development of the skeleton will be affected more as compared to the development of soft tissue. That's what that sentence means. As a result of this disproportionate rate of growth, the soft tissue are likely to enlarge excessively, giving the child with cretinism an obese, stock, or short appearance. So you have a stocky or short appearance because the bone, the skeleton is not developing well. The soft tissues, to some extent, they are not affected that much, so they are developing. Occasionally, the tongue becomes so large because it's a soft tissue, so it will enlarge. It becomes very big, so large in relation to the skeletal development of the cranium, that will obstruct swallowing and breathing. So you can't swallow properly, you can't breathe properly because the tongue is so big and is obstructing those pathways for the food and for the air and respiratory system. So you can see this child with cretinism, the tongue is protruding outwards because the soft tissue is developing, the skeleton is not developing very well. They have a stocky stature, very short and obese, more like obese because the soft tissue is developing as opposed to the skeleton. Then these infants, they normally die at a tender age because of the challenges in swallowing and breathing. So they can die because of cretinism. So cretinism is due to lack of the thyroid hormones that are required for development of the body. Thank you very much. We are done with lecture 5 of endocrinology. Next time we meet, we'll be looking at lecture 6 of endocrinology. This is where we're going to end for today. Thank you very much for your attention.